Dear, dear colleagues, welcome to the third Congress of today. Hope you are all fine and healthy. Today I feel privileged to announce you a milestone lecturer, researcher and an educator in the field of pediatric dentistry. As an NIDR research fellow, following graduation from New York University College of Dentistry, he obtained a Master of Science degree at New York University Graduate School of Arts and Science. His research studies start back in the 1960s. In July 1977, he published the book Your Child's Teeth, A Parent's Guide to Making and Keeping Them Perfect. In 80s and 90s, he focused on caries prevention, public health, and dental education. In 1993, he wrote a second guidebook for parents, Growing Up Cavity-Free, which was also translated to Turkish. He has published monographs and over 200 scientific papers in the field of orthodontics and pediatric dentistry. In recognition of his academic abilities at the New York University College of Dentistry, he was appointed division head of growth and developmental sciences. In that position, he was given the responsibility of coordinating prevention, pediatric and orthodontic education. He is a past president of the American Academy of Pediatric Dentistry, and he represents FDI as a delegate in the United Nations. His present activities include developing international education programs designed to promote oral health, and he is a member of the Academy for Sports Dentistry. Today, he will enlighten us about changing concepts in pediatric dentistry, and we will have the opportunity to learn how our profession has shifted from drill out and fill to fill up and protect, and steps taken so far at the level of caries prevention. Dear colleagues, it's my honor to welcome Professor Emeritus Dr. Stephen J.Moss, who can also call teacher of my teachers. Welcome. Good morning, Dr. Moss.
Good morning, Professor. Thank you. Thank you for the invitation. It's a pleasure to be here. I'm talking to you folks from my home in Florida, which sort of faces the Atlantic Ocean, which faces the countries of the two previous presenters, the gentleman from Spain and that lovely woman from Portugal. And this morning I'm going to, well, I guess for you it's this afternoon, I'm going to speak with you a little bit about some of the changing concepts, and if it's okay with you, we can get started, okay? I'd like to start by telling you what I'm going to tell you, and then I'll tell you again what I'm going to talk about. I'm going to talk about the cause of early childhood caries, and I'm going to point out to you that it's related very, very significantly to saliva and enamel, and that the major cause of early childhood caries is the maturation of enamel. And that same enamel maturation is probably one of the major causes of caries, both in the adult and in the child. And it's my feeling that if you understand this concept of enamel maturation, you will have a way of working with parents and caregivers to prevent the disease. One of the most interesting things about the condition early childhood caries is that pediatric dentists rarely, if ever, get to see early childhood caries in their own sons and daughters. So let's get started. And we're going to start by talking first a little bit about how saliva works in the mouth and its relationship to the development of the various caries lesions we see. One thing I'd like to start by pointing out is that dental caries, as we know it, is a site-specific disease. And what I mean by site is it occurs in certain locations. It occurs in the primary teeth. It occurs when we place bands on teeth in children. It occurs at the cervical region. It occurs interproximally, and it occurs on the occlusal surfaces of teeth. And in order to understand why caries occurs in those particular areas, I think it's important to look at saliva. Saliva is a most important body fluid. Saliva works for the teeth just the way that the bloodstream works for the cells of the body. Saliva removes waste, it contains proteins that fight disease, and it offers a line of protection against microbial invasion. When I first started to practice, I was always concerned that saliva was just something that got in the way, and today I understand its importance. Now, as dentists and people concerned with maintaining enamel structure, I think it's important to understand first that saliva contains calcium and phosphate. In fact, it contains calcium and phosphate to the degree that it is considered supersaturated. And when a tooth is in the mouth, there's a constant exchange between the mineral in the tooth and the mineral in the saliva. In fact, when you lose saliva, the tooth degenerates extraordinarily rapidly. Think, for example, of the cases where we have radiation, and within weeks, once the salivary glands are destroyed by the radiation, the teeth break down extremely rapidly. One of the things to know about saliva is that it does not mix in the mouth. Saliva is formed by the three major salivary glands, the submaxillary, the parotid, and also by the glands that live in the mucosa around the lips. Saliva is secreted and flows out of the mouth. It stays in the mouth for maybe 2, 3, sometimes 4 minutes, but it is constantly being secreted and flowing out of the mouth. There are places in the mouth where salivary flow is very rapid, and those are the areas in the mouth which are generally very healthy. And there are places in the mouth where saliva flows slowly, and those are the places where we generally see disease. If I'm a surgeon, I want to place my sutures in an area where I have rapid salivary flow. Let's take a look at some of the various sites where caries forms. The most common being the proximal surfaces between teeth. And one of the major reasons why the caries forms in this location is that it's an area that saliva doesn't get to. The saliva flows over the tops of the teeth, but never gets into this particular area. When saliva doesn't reach that area, there's no opportunity for an exchange of mineral back and forth between the saliva, and so this becomes a susceptible area. A little later in the presentation, I'm going to make the point to you that this same area where we don't have salivary flow are areas on the enamel surface that fail to mature. When they fail to mature, over time, those areas also become sites where caries occur. And the maturation of the enamel is dependent on the flow of saliva soon after the tooth erupts into the mouth. When a young man or a young woman wears orthodontic bands, the bands deflect the salivary flow. Experienced pediatric dentists and experienced orthodontists know that when we remove these bands, the area we're going to see that has demineralization is going to be mostly in the upper and not in the lower. And that's a very interesting question. Why is the upper more susceptible than the lower? And the answer is, since saliva doesn't mix in the mouth, the only saliva that really wets the maxillary incisor teeth is the saliva that comes from the mucus glands under the upper lip. And most people don't realize that the chemistry of the saliva is different for each of the glands, and the glands in the upper lip are very, very low in bicarbonate, which neutralizes acid, and extraordinarily low in mineral. So they don't do as good a job as the submaxillary or mandibular glands in providing mineral for the maintenance of the enamel. And here you see a white area, the typical white spot. And I might ask you to just stop and think for a second and answer the question to yourself. Why is this white spot white? What does it represent? Well, what it represents is an attempt of the saliva to maintain the mineral structure. And as mineral comes out, more mineral comes in, and it's deposited in a way that is not as translucent, because instead of being enamel rods, this is a precipitation directly on the tooth. Another example of caries we see are the caries that occur in older people, and they occur at the gingival margins of the teeth. And one could ask the question very quickly, why do these teeth maintain themselves for 30 or 40 or 50 years and then all of a sudden start to show erosion and breakdown in this particular area? And the reason is rather easy to see in this picture of the father and daughter. In the daughter, the salivary highway is close to the cervical areas of the teeth. As you get a little bit older, what was once a salivary highway has now dropped down, and there's no longer a rapid sustaining flow of saliva at the gingival margin. It's much further down. And of course, with adults, they start taking medication, and the majority of medications that adults take today are all things that decrease salivary flow. Very much like when an infant falls asleep, your salivary flow and the infant's salivary flow decreases, and they're more susceptible to caries. The other place that we see caries all the time is on the occlusal surface. And one could ask the question, well, if saliva is flowing across the occlusal surfaces of the teeth, why do caries form there? And the reason is that they are really salivary deficient areas. In areas around the world where children use a fluoride toothpaste, by and large, if they use it twice a day, the only caries that occur are on the occlusal surface, not on the smooth surfaces. And the real reason is that saliva doesn't reach down into the pits and fissures of the teeth. Saliva is a very viscous substance, and it forms a meniscus so that the area at the bottom of the pit or the fissure is a salivary deficient area. Fluoride is not the preventer of cavities. The preventer of cavities is the saliva. When fluoride is present in very small quantities, fluoride aids the saliva, as you'll see in a few minutes, in providing mineral for the tooth. But the minerals for prevention and sustenance of the tooth come from the saliva. One of the advantages of a dentifrice is that it contains a detergent, and the detergent breaks up this viscous nature of the saliva and allows the saliva to flow down into this particular area, into the pits and fissures. So one can say that if an area in the mouth is salivary deficient, it's an area that has a very high susceptibility to dental caries. Now let's get to our specific subject, and that's the subject of early childhood caries. Although I believe today what we say about early childhood caries absolutely applies to caries we see in the adult dentition. Here you have a picture of newly erupting teeth. This is the time when the enamel on the tooth is beginning to mature. Most people don't realize that the maturation of the enamel in both primary and permanent teeth occurs during the first weeks and months the tooth is in the mouth. If that maturation doesn't occur, then the tooth is very, very susceptible to breakdown. The first teeth that erupt into the mouth of the child are, of course, these maxillary incisors. And as we talked about with the orthodontic bands, if saliva doesn't mix in the mouth, the only saliva that is going to wet and maintain the maxillary incisors in an infant is the saliva that comes from the minor mucous glands. And if we take a look at it, the viscosity is very high, so that means it flows slowly, and there is almost no mineral in that saliva, and almost no bicarbonate, the natural chemical in saliva that helps to neutralize acid. It's almost totally missing. And that's one of the reasons why the maxillary incisors in the infant are so susceptible to the development of early childhood caries. When you sleep, your salivary flow diminishes greatly. When you chew, you increase your salivary flow. In fact, the only way to increase salivary flow is by chewing. When you chew and you increase your salivary flow, you change the chemistry of the saliva. Stimulated saliva contains more mineral and less protein. It's less protective against disease, but it contains more mineral for protection and maintenance of the tooth structure. So if I'm a parent and I want to keep saliva in contact with these teeth, I have to do something. Let's examine now this subject that I have referred to as maturation. When a tooth erupts into the mouth, it has a natural pellicle, a protein film on it, and that enamel pellicle is the result of the enamel organ coming together on the surface of the tooth. That pellicle, which I'm trying to show here, that pellicle is a membrane through which mineral moves from saliva into the tooth. On top of that pellicle is another pellicle, which settles immediately out of the saliva. And that's called the acquired pellicle. The crystal nature of the enamel surface pulls protein out of saliva and causes it to form a pellicle on the top of the tooth. And so a newly erupted tooth has two pellicles, the acquired and the natural pellicle. And these separate the tooth from the saliva and act as what chemists would call a perm-selective membrane. In other words, it means that the membrane or the separation is what controls which way minerals go. But the enamel surface, in order to mature, also has to have some dissolution. And that, of course, occurs by the development of the biofilm, or what we used to call plaque. And today we know that the shape and size of the pellicle matches exactly and precisely the microorganisms that are in everybody's mouth, the microorganisms that are acquired from the caregiver to the child. And so what you have is a transfer on this pellicle, back and forth of mineral. And it only occurs when first there's some demineralization. And this rather complicated slide is just a way of showing that carbohydrates, whether they're in the milk or juice or what is ever fed to the infant, are broken down by the saliva into glucose, and then the microorganisms in the mouth digest them make small amounts of saliva, small amounts of acid, and the surface of the tooth begins to dissolve. And this drawing that I have here is an attempt to show you what the enamel surface of a primary tooth looks like chemically. These are enamel rods, and this is the formula of human enamel: carbonated hydroxyapatite. If I'm an anthropologist and I find a tooth during an excavation, and I want to know whether it's a human or an animal tooth, I analyze it, and what's most characteristic of the human teeth is, by and large, they're loaded with carbonate, and they're hydroxyapatite with carbonate attached to it. In order for the tooth to mature, the surface area has to lose that carbonate, and we have to have a more pure hydroxyapatite. Now, you're probably thinking, well, what does fluoride have to do with all of this? Well, if fluoride happens to be present in very minute quantities within the pellicle, the fluoride facilitates the movement of mineral from the saliva into the tooth. And what I'm explaining to you that in that rather complicated sentence is that the primary action of fluoride is a topical one, and it is dependent not on making the tooth stronger. The major action of fluoride in preventing cavities is that it gets into the pellicle, which is on the tooth at all times, and it turns that pellicle membrane into one which absorbs mineral from the direction of the saliva into the tooth surface. There is eventually, in the very, very outer surface of the enamel rods, the incorporation of some fluoride, and that gives us the chemical composition of fluorapatite, which of course is a much harder structure. So now, if we look at early childhood caries, and I use the terminology, the condition early childhood caries, because it's not a disease, it's not an infection, it's not caused by microorganisms, it's caused by the fact that these massive areas on the teeth, never had the opportunity to mature, and they break down very quickly. So let us answer the question, what is it that keeps the primary teeth in children who have early childhood caries? What is it that prevents those teeth from maturing? And before we do that, let's just take a look at, you can see the early breakdown in the lower incisors, and then the tooth just falls apart. And you can notice that, the rapid way that the pulp chambers here protect these primary teeth, even though they've lost their covering. It is not the bacteria. The bacteria that come from the mother to the child are highly important. The mouth has to develop an oral flora and fauna which becomes individual to the child and prevents transient organisms from finding a place to grow. When children either breastfeed or use a bottle, they provide nutrition for themselves, but they also provide a coating over the top of the pellicle. And if that coating stays for more time than saliva has a chance to touch the teeth, it prevents the tooth from maturing. It prevents the normal maturation of the enamel. And most of you have heard the terminology non-nutritive feeding, using either the breast or the bottle as a pacifier. When that happens, there's no time for the saliva to come in contact with the tooth. The tooth is covered with a film of microorganisms that overgrow, preventing the transfer of mineral from the saliva into the tooth. And the prevention for caries, early childhood caries in infants, is most simply the wiping of the teeth. Nothing else, just the wiping of the teeth. But this is a very, very difficult thing to do, because worldwide, most caregivers are afraid of entering the mouth of the child. And if we were to teach wiping the teeth as the preventive measure, and not and ignore using a bottle or the breast as a pacifier, we would be in a much better position, because when parents use a bottle or a breast as a pacifier, they are using it for a whole bunch of cultural and social reasons, which it is much too difficult for health professionals to interfere with. When we come to wanting to get caretakers to wipe the newly erupted teeth during the first few weeks after eruption, what we have to overcome is the fear of the caretaker of creating infection in the child's mouth. And today we understand that once the oral flora develops enough to make acid to start the maturation process, that oral flora is also protective against the invasion of foreign organisms. Dental caries is not an infectious disease. Dental caries is a problem that occurs when there is an overgrowth of the natural organisms within the mouth. Probably we would do much better if instead of calling this early childhood caries, and in my lifetime, the name has changed from baby bottle tooth decay, nursing bottle mouth, etc., to early childhood caries, which is more sophisticated. But perhaps if we could change the name again to tooth cleaning neglect, we would have the tool for enabling caretakers to be brave enough to go into the mouths of children. So let me summarize what I've said to you. In early childhood caries, some of the concepts are changing. First, it is not the transmission of microorganisms from the mother to the child, infecting the child with bacteria which are acidogenic and causing an acid condition. Maternal transmission of microorganisms is important. It allows the child to develop their own natural defense and their own protection. There is no conflict between breast or bottle. Either one of them that is used for non-nutritive feeding, in other words, using either one as a pacifier, causes a condition which could lead to the development of early childhood caries. But even if the child used the breast or the bottle, if the caretaker spent a few minutes each day wiping the teeth, it would generally be enough to prevent early childhood caries. The perfect example of that is the sons and daughters of pediatric dentists almost never suffer from early childhood caries. It's not that their parents went to school and got an education. It's that their parents are not afraid of going into the patient's, the child's mouth. Fluoride varnish teaches away from what has to happen. In order to have healthy primary teeth, it's necessary to now allow and enable the enamel to mature. So let's look now, as we conclude, at some of the clinical implications, the myths and misconceptions. First, caries in primary teeth does not spread to the permanent tooth. No, caries occurs because a tooth is immature, and when a tooth is immature and the enamel has not formed properly, it becomes more susceptible to acid demineralization. Caregivers do not spread infection to their offspring. More sugar does not cause more cavities. It's the frequency of ingestion. Non-nutritive feeding creates a danger. Wiping the teeth can overcome that danger. Brushing twice a day is important to maintain oral health. Yes, brushing twice a day brings fluoride to the mouth. The fluoride stays in the mouth, on the teeth, in the form of calcium fluoride. When there is an acid condition, the calcium fluoride dissolves and it releases the fluoride into the pellicle just when and where it's needed. And then there's the concept that gingivitis leads to periodontal disease. And of course, that's not so. Gingivitis is important because gingivitis allows immunoglobulins to come from the gut into the mouth and maintain oral health and a normal oral flora. I'm going to stop right now and see if we can have some questions.
Your opinion on this subject? Can you hear me, Professor?
I do hear you. Yes, sir.
Do you want me to ask the question again?
Yes, I couldn't. No, I did not hear your question. I'm sorry, but we're still showing my screen.
We have many questions. I would ask to.
Good. Let's please. That's why I stopped talking.
Yes, a few of them. Professor Tatekin thanks you a lot for your presentation, and she wants to learn what you think about non-fluoride natural herbal toothpastes or dental cream to effect of remediation on caries lesions.
I don't think they make much difference. I think in my opinion, toothbrushing helps because it has a detergent in it, and the detergent helps salivary flow. If the dentifrice doesn't contain a small amount of fluoride, then there is nothing that I know of that toothbrushing does other than remove food particles. The herbs are not going to help in the maturation or the mineralization of teeth.
I see.
The remineralizing agent is the saliva. Fluoride only works topically, and it only works because it helps mineral move from saliva into the tooth surface.
Thank you. And so you have answered another question probably from Professor Yanıkoğlu. She asks if you, which one is more important, she asks. Is it the toothpaste or the toothbrush? I guess your answer is the toothbrush, or do you want to comment more on this subject?
It's very hard. It's a great question, and it's very hard for me to say that toothbrushing does very little more than help to remove some food particles soon after eating. Saliva does an extraordinarily good job in washing the mouth out. It contains enzymes that break up starch very, very quickly into sugars, and once there's sugars, they dissolve from the mouth. So toothbrushing helps only because it brings some fluoride into the mouth. That fluoride stays there, and when there's an acid condition, it enters in very, very small quantities onto the tooth surface and aids in mineralization.
Thank you. And you mentioned a lot on saliva in your presentation. So for those caries susceptible areas, like interproximal areas and fissures, what do you suggest for the action of chewing gums? Could it be helpful for salivary action?
The only way to stimulate saliva that I know of is not, other than chemically, is by chewing. Mm-hmm. And nature provides that the stimulated saliva is much superior in removing food particles and providing mineral. The mineral content of stimulated saliva is higher than the mineral content of unstimulated saliva. It's nature's way of providing mineral when and where it's needed. Chewing gum is a very effective way of stimulating salivary flow.
Thank you. And one last question. I guess we are almost up to time. Sorry that I control my notes. You mentioned the importance of wiping for those very early years. I mean, for those early years that children can be very uncooperative. So if you compare the effectiveness of brushing and wiping, which one could be more effective?
I cannot recommend the use of a toothbrush in an infant with early erupting teeth.
Yeah.
Wiping with anything is much more effective than trying to brush the teeth.
So we should keep the tooth free of plaque, as far as I can understand.
Wiping once or twice a day, teaching parents or caregivers to wipe the teeth once or twice a day will make them like the sons and daughters of pediatric dentists. And that is the immunity. Concentrating on the concept of don't use a bottle as a pacifier, don't use nursing as a pacifier is a good idea, but over the years has proved highly ineffective because of the social and cultural needs associated with that activity. It's nice to say, but it's ineffective by and large on a large scale. The only thing that I have seen so far that stands a chance is wiping the teeth, but to get people to do that is going to be very difficult. And nothing has really been ever successful in public health other than seat belts and stop smoking.
Yes.
But that's what we're going to have to get to. If we get to the point of wiping to allow maturation to occur, then we have the prevention of early childhood caries. It's easy to say. It's difficult to make happen.
Yes, thank you very much. Maybe we should encourage toothbrushing companies to produce tooth wipes and maybe
it's a good idea.
Advertisements more.
It's a good idea, and some companies are doing that right now. Yes.
Thank you. And I'm not sure if we have time. There is one more question. How could we supply mineral contents in natural ways? I think you have already answered this question. And Funda Yanıkoğlu professor asks, can we think tooth floss as a wiping agent or wiping instrument? Tooth flosses?
I think by and large, when we're talking about children, especially, flossing has not a lot of benefit, and is, to me, is a, I hate to say this, it's a waste of time.
I see. What about in mixed dentition period? Think the same, I guess.
Well, the caries are occurring, below the contact point, and we don't have a lot of data to support the concept that flossing is going to prevent caries. We just don't have it. In fact, the two controlled studies that were done seem to show just the opposite.
All right, thank you very much. I'm just checking the latest questions. Yes, you have already answered many of them. Thank you very much for your inspiring presentation.
I hope not too confusing. And thank you very much, all of you, for inviting me.
You're welcome. We are happy to attend your session. Thank you.